Good afternoon and welcome to Acuity Adaptability. Is this the new normal? It's been clear that this current pandemic has definitely challenged the traditional delivery patient care model in healthcare and leading many of our healthcare organizations to look for a better, more flexible model. Today we brought to you a very diverse panel. We've got an owner, a clinician, an architect, and a technologist here to discuss this concept of acuity adaptability and whether or not we think this care model has a place of it in the future of healthcare delivery. My name is Mike Zorich. I'm a principal and the director of healthcare for IMEG. I'm a mechanical engineer with 20 years experience in the healthcare industry, and I've been exploring this topic for many years with several clients. Joining us today is Luke Lydon. Luke is the assistant director and chief architect for the University of Iowa Hospitals and Clinics. He's a registered architect overseeing the design of nearly 5 million square feet of facilities. Luke spent 14 years focusing exclusively on the design of healthcare facilities, looking for ways to improve the patient and visitor experience. And over the last 4 years, he's overseen over $1 billion worth of construction. Second, joining us today is Erin Clark. Erin is a registered nurse by background and a healthcare operations specialist. She's the owner of Clark RN. She's worked with healthcare organizations across the country as they design and activate new healthcare facilities. She's worked in a number of clinical environments, including acuity adaptable units, and brings her experience and expertise to the organizations as they develop new clinical operation models. Next is Corey Guardi. Corey is a biomedical engineer for IMEG, has nearly 20 years of experience in the healthcare industry. His experience ranges from IT management, providing advisory services for large integrated healthcare systems. His technical expertise, clinical aptitude, and innovative approach bridges that gap between the technology, the A&E world, and the clinical operations. And then finally joining us is Mark Geisinger. Mark is a principal and senior healthcare designer for ZGF Architects. He's located in Seattle with 25 years of experience. Mark began his career as a medical student before pursuing architecture. He's particularly sensitive to architects' ability to support the care of patients and to deliver healing environments to staff, patients, and their families. He's served in a leadership capacity at numerous healthcare facilities and worked with administrators, physicians, and staff to incorporate lean strategies into the planning of award-winning projects. So with that, we're going to jump right into it. And we'll start with you, Mark. Can you first, let us know, define what is acuity adaptability and what concepts it includes?
Sure. Thanks, Mike. Thanks for everybody for joining. So when I think of acuity adaptability, to me, it's a space that affords care to adapt to varying clinical needs of the patient. And so the clinical expertise is transferred to different rooms, not the patient. And this can be applied to inpatient units as well as emergency departments or outpatient clinics. And it's also, I think, important to me and for our field to think of it in terms of time. And so there's the day-to-day patient stay, from admission to discharge. There's also the intermittent response. So can you respond to disasters and pandemics, flex to emergency double units or quarantine unit, for example? And then there's the future flexibility. So having a universal footprint that would allow change to different care models, depending on the patient needs in the community. And so from a design standpoint, that's what we tend to focus on and are seeing a lot of. So the design is somewhat easier, though. It's the clinical skill set that makes this all work. So with that, I think we'd like Erin to help us understand more about that.
Yeah, Erin, can you kind of tell us from the operational standpoint? Mark had mentioned design at times can be the easy part, but from an operational standpoint, what are you seeing with the acuity adaptability and what are some of those challenges?
Sure. So the acuity adaptability model is not a new concept, but it has evolved as more and more research is done on the effectiveness of the adaptable units, looking at different types of settings and different clinical service lines. So as Mark had mentioned, the idea behind the flexible units is to bring the care to the patient along their hospital journey, and focusing, from my standpoint, particularly on the hospital. But this decreases the transfers between units to unit, which has a number of positive effects, but also presents some challenges. So from a positive standpoint, this obviously decreases any wait time the patients experience when they're waiting for beds to open up on other units. And this also has a downstream effect for the entire hospital throughput, even as far as the ED, as they're boarding patients waiting to get into these inpatient units. So we see some efficiencies built in with an acuity adaptable model as we look at delays in care and waiting for other beds. This also has a positive effect on the patient and family experience because it allows for more continuity of care and less handoffs between providers. So if I'm Erin and I took care of a nurse who was an intermediate or step-down patient on Monday, and that patient's been downgraded to a med-surg level of care, I can still take care of that patient. I know the patient, I know their history, their medicals, the medications they're on, and their entire plan of care. So from a patient and family standpoint, that's really comforting for them to know that they're seeing some of the same providers that they see on a day in and day out basis versus transferring from unit to unit and handing over from provider to provider. And the ability to do that is really just allowing for the adjusting of the staffing models on these units and the ratios to fit an acuity adaptable model. This also increases the likelihood of decreasing infection transmissions as you're not transferring patients to more areas in the hospital. And it also decreases the likelihood of missed or redundant care, again, stemming from some communication gaps that often happen when you're transferring handoff of care from one provider to another. Where we start to see the challenges with this model, though, is really in the competencies of the different service lines and levels of care. And this can actually impact patient care as well. Because not all step-down patients and med-surg patients are alike. So what most of the research shows us is that a fully acuity adaptable model actually creates more challenges than it does benefits. And when I say fully acuity adaptable, that means from the ICU level of care all the way down to the med-surg level of care. Most organizations have adopted an adaptability model that really excludes the ICU and focuses more on the non-ICU patient population. The other consideration is really the overall of the hospital size and the volumes of various service lines to be able to implement a service delivery model such as acuity adaptability. The number of beds per unit and the location of these patients has an impact on how well the model works. If you have a larger unit on a horizontal platform, you have more flexibility of movement of staff versus a smaller unit or more vertical layout. And the last thing I'll mention here from an operational standpoint that often is overlooked is, if you're working with an organization that's considering this type of model, one thing that really cannot be discounted is the level of culture change and the resistance from the staff that they will see as they're asked to widen their scope of competencies to be able to provide care at a higher or lower level of care than they've been initially trained. So just a couple of operational considerations if you are working with an organization looking at this type of model.
Thank you, Erin. Yeah. So Luke, Erin was kind of talking about maybe a little hybrid of a few fully acuity adaptable, but from an owner's perspective, what are you seeing with this model? What are some of the challenges that you're concerned with?
Yeah, so we see a lot of value in doing this in both the inpatient rooms as well as like soft spaces that could be flexed into in-surge type situations. During the recent COVID outbreak, our team led an exercise where we did examine all kinds of areas throughout the hospital, trying to determine what could be used in a surge situation. And we found a lot of solutions, but nothing that was really ideal. And so that really was an eye-opening kind of exercise for me. In that going forward, we're going to try to implement some of those things so that as we go forward with new construction projects, that there are some adaptability components that we will work in just from a soft space as well as just the actual patient care spaces to make sure that we could absorb that in the future. So I think that's the ability to flex is a huge benefit. I would say the disadvantage would be cost.
Yeah, that's one of the common themes that we're hearing throughout. Now Corey, they'd mentioned a little bit, both Luke and Erin, about the flexibility, maybe a little bit of a hybrid model. Obviously, with the current pandemic, technology has been accelerated both on the adoption of telehealth and virtual care. What are you thinking and seeing as it pertains to acuity adaptability from a technology standpoint?
Yeah, sure. I think the interesting element of all of this from a technology perspective is the rush adoption, like you said. And I think going forward, a lot of these technologies are going to be a mainstay in really every room, regardless of the acuity. Things that I think that a lot of organizations either valued engineered out, whether it be a digital whiteboard or potentially even digital signage on the outdoor of the patient room that could be tied to the electronic medical record and demonstrate, the patient fall precautions, et cetera. You're going to see that in the design going forward. The concept of contactless care, I think, is going to be a mainstay. And it not only provides, a safety factor for the caregiver environment, but also an experiential element for the patients as well. So, there's concepts where we're seeing a much more adoption where a camera is in every room rather than just ICU or monitored bays. That camera can be a multi-purpose, and gone are the days of where it's only utilized for EICU or telesitter or what have you. It's going to be utilized for the patient experience to talk with their family members. That was one of the biggest things that I think all of us have learned is that, the being able to talk with your family members is such a key and pivotal thing. And especially with the pandemic, the BYOD elements, you're going to see a lot more of that. And we have to remember that, again, the concept of telemedicine covers such a broad spectrum from just pure collaboration for care providers to actually providing care to providing a monitored patient. So you're going to see a lot more of that in the rooms. The evolution of medical equipment to be much more mobile is definitely growing. There's always been a mobile CT, but just within this last year, we've seen mobile MRIs now. So what does that do from a technology perspective in those rooms, and do they have the space, and does it make sense? But I think that just the common table stakes things are going to be in there for a heightened experience, again, not only for the caregiver, but also from the patient side as well as the family too. I mean, we got to remember back to the soft spaces. There needs to be an area of respite in these rooms, for patients' families and the like.
Okay, thank you. Now, Mark, Luke mentioned cost, and kind of coming back to that, in theory, Acuity Adaptability is bringing the care directly to the patient. So by theory, we're designing to the highest denominator, right? The worst case scenario. So there's going to be this propensity to overplan, over-design, provide more utilities. In theory, there's probably a somewhere in between. What are some of your clients saying that maybe isn't the full acuity adaptable, but somewhere close?
Yeah, it's a good topic, and it's coming up on most every project. And the way we've been thinking about it is more in terms of, like, you think about a city, and you plan a city, and you know that in the future you're going to have a freeway going through from east to west, and so you build in a right of way. And so that's kind of what we've been doing for bed units and other departments is, let's plan this so that we have the right of way if we need to bring in infrastructure, and we've got the footprint for an ICU, but we know that we can operate it in a lower acuity. And we don't have all the mid gases on day one, but in 10 years, you could renovate it and bring it up to an ICU level. So those are some of the strategies we've used. And they've been implemented in a few academic medical center settings.
Anything from similar, Luke, from your opinion, from an owner standpoint, any of these in-betweens that seems to make the most sense, whether it be a certain department, certain location that, hey, we don't want to go to the full acuity, but this is maybe a halfway point. Any thoughts from an owner standpoint?
Yeah, there are a couple things that we're looking at. So number one of our studies right now, we're looking at a new ICU unit. And so we have several kind of ICU departments that need to expand, but not enough to the point where they can, they'll fill a full unit. And so we're looking at some adaptability there, both, for different types of ICU patients could be in there. But then also if some of our other units are full, as was mentioned, the ICU is the highest level of care, but we could keep patients there longer, step down patients. So we've been thinking about that. We also have an emergency room department that's ongoing. And so that's obviously an area that, that's the first place that might get hit in a surge capacity type situation. So there are some open areas that may be designed as part of that, just to be able to expand to absorb those patients. So those are the two things that we're thinking about right now.
Great. Aaron, you mentioned culture and the operations as being maybe one of the biggest hurdle. the three of the four of us on this call are designers or have had the design aspect, and to an extent, that might be the easy part, but how do you solve that problem operationally? And are there certain types of health systems, I'm thinking more rural health or locations where maybe this applies or could be a better solution versus your large medical centers or academic medical. Is there any thoughts there where this may apply better?
Yeah, but I think some of the areas that we've seen some of these acuity adaptable models work really well are in those kind of smaller rural areas where the mix of patient populations are just by nature going to be in the same area because there's such a few number of beds versus a larger hospital where the number, as the bed number increases, so does the delineation between service lines and acuity levels. We've also seen the service lines where this works well in hospital admissions with more predictable plans of care. So for example, some of your cardiac patients, your ortho patients, your neuro patients, where there's clear parameters and criteria to be met, and their plan of care is relatively predictable. And so if you have those types of patients in one area, it's a lot easier to flex the acuity level and the staffing models because it's relatively predictive. And so that's where we see some of these work very well. But again, as you get larger and larger hospital with a larger number of beds, you're going to see more and more defined acuity levels and service levels in these in the same areas. So there may not be as much acuity adaptability because they have the volumes to fill very specific patient types in those areas.
Okay, great. Now, Corey, one of the things with acuity adaptability, if I'm changing my floors and have a different level of care at different places, one of the big challenges is wayfinding, and how do I get from one? How do I notify the staff when they enter, notify family? Yeah. So, what are some solutions from a wayfinding point that could help support an acuity adaptable, whether floor, department, or whatever the case may be?
Yeah, I think you're going to see a much more increased adoption of the digital experience, and that could be tied back to the digital front door, leveraging what has been around for several years in a much more broad way. The RTLS, you're seeing much more of the blue dot navigation tied to BLE, kind of the Googles, for lack of better words. And you're going to be able to have an interface specifically for the care providers because they're going to be potentially badged, tied to the rooms and what have you. But it's going to provide a much more real-time awareness of the environment for the care teams as well as the patients and the families throughout the whole organizations. And that could actually start from the time that they leave their house, the patients or even the providers, to the time they become on premises, whether it be garage, or a parking lot. You're going to have a much more awareness of the environment. That can be tied into digital signage as well. So as you're walking through the organizations, you can verbally pop up on the screen and to say, "You are here," kind of mentality, and then help you guide and to say, "No, you cannot go in those particular areas," based off of, security or infection controls. The other thing that's also going to be able to provide is just a physical security. So, facilities as well as public safety is going to be aware of areas that are not accessible to a standard public or what have you. And then you're going to have a much more broader control of doors and locks and signage so that it is a much more controlled environment rather than just a reactionary environment.
Okay, great. I'll just throw this out to the group, but one of the questions we often get is, okay, if I want to go down this road of acuity adaptability, again, bringing all the care to the patient, whether mobile medical equipment, all, storage, what's a rule of thumb for the size of a patient room, for an acuity adaptable floor or patient room? Does anyone have any insight into that kind of rules of thumb?
I'm going to say one just thing before we go to the physical side, but from a technology perspective, and I've actually had a healthy conversation around this, is that yes, there is going to be a proliferation of wireless, and there is going to be a lot more things on the Wi-Fi, but sometimes that doesn't make sense. So I think there needs to be a balance and a strategic discussion with regards to a physical data jack versus that's going to be static all the time, or that can be flexed based off the incoming equipment, and then be able to have your capacity from a wireless perspective and to that mobility, because you are going to have a heightened level of medical equipment to IT to insert patient BYOD, Netflix streaming, et cetera, that's going to be on your Wi-Fi. So those are all things that needs to be taken into consideration, be Wi-Fi versus static.
Regarding room size, I was thinking about a renovation we did for a cardiac critical care unit on the West Coast, and it was a 1970 building that had very small rooms, and they have adapted and they make it work, and it's amazing. And so, 150 square foot room is doing amazing cardiac work, and but on the other hand, a 305 square foot room is sort of what we're seeing, in today's newly designed rooms. So, but and then you go even further and say, by the time you get all the equipment in and you've got a fully operating ICU, it seems like the room is never big enough. So,
yeah,
it's all about adaptability and getting the right equipment in the right place.
Great. Now, Aaron, one of the things we've definitely seen over the last year is just all the stress that this whole pandemic's put on our caregivers. And there's concerns that a lot of people are leaving the industry. There's also a concern about the lack of nurses and down the road. Does Acuity Adaptability process help support a potential shortage of nurses in the future, do you think?
I think that's a great question. And I think that with an acuity adaptable model, and again, they're not all created equal, but
Sure.
With an acuity adaptable model, one nurse would have the ability to take care of a larger set of patients. So instead of being just trained in one area with one level of acuity, that nurse would be able to take care of a wider range of levels of acuity. So that flexibility and floating nurses from area to area would make that easier. They wouldn't be limited by not being able to send a nurse to one unit because she doesn't know how to take care of that particular type of level of care. So I would imagine there is some flexibility in there. And I think that what was really interesting in the last year, and I think that the perception of what some of these, nurses and institutions are able to be able to do, that kind of rush adoption. We saw a lot of, I think one of the most interesting things was we saw a lot of when the elective surgeries were all canceled, in all these hospitals, all of those OR nurses were assumed into the inpatient units. And what's really interesting is they're not trained, an OR nurse is not trained in how to take care of an ICU patient. And they are completely, even though, we all get the same training, when you get into the field, you are very much trained to your specific specialty. And so what was really interesting that came out of that was these organizations that adopted a different type of nursing care delivery, where we looked more at team nursing and really utilizing the best, the most, trained components of each type of nurse to be able to take care of those patients. And so really that in and of itself was adapting to that environment. But I also do think that, you mentioned kind of the culture and that change component before. I feel like the mindset of some of these organizations in terms of what they can withstand and rolling out these new types of models is shifted a little bit because, if you look back on what we had to do during COVID, they still made it happen, and it was a lot of these nurses stepping up. It was a lot of the organizations stepping up and providing support for their nurses to really be able to take care of these patients, even if it wasn't their specialty. They had to do just-in-time training with a lot of these nurses that were in different units. So if there was a longer term, more planned solution as they're looking at developing an acuity adaptable model, they can take some of these lessons learned from what happened during COVID and how to really help with that change and get nurses excited about expanding their scope of practice based on some of the experiences that they went through, which I think is very interesting.
Great. And I think that brings up a good point, just lessons learned from this current pandemic. And it sometimes is similar to this acuity adaptable, but, finishing up here, Luke, any lessons learned that you guys have came across, during this last year that might allow for flexibility, something you didn't know that you may apply going forward?
I don't know. I think just the realization that we don't know what we don't know. We don't know what's going to be coming down the line. And so just building in as much flexibility as we can now. One of the areas that we looked at as a surge capacity were exam rooms for a certain specialty that also had medical gases. And so I think just, building flexibility as much as we can, I think is important. I think the the struggle that we're going to run into is administration and others who already think that we're too expensive when we build stuff, adding in cost. And so I think the only thing that I can think as a way to kind of push back on that or get around that is just helping people to realize that it's cheaper to do it now than it is later, and that it's going to save us and help us provide better patient care and more flexibility in the future. And so that's one thing that we have looked at through some of the things that we do. For instance, one of the head wall systems that we use is one that you can easily kind of pop the panels off and add additional gases and power. It's nothing you're going to do in a day, but it will provide us the flexibility going forward. And so just, I think by picking the materials and the products that are going to help us be flexible in the future, I think is going to be the most beneficial for everyone.
I know user group meetings are much different now, where we as designers, Mark as an architect, myself as an engineer, bringing those options to you as an owner, saying, hey, here's a potential, whether it be more gases, whether it be air changes, filtration, and having a much different discussion, I think is something that the whole industry is going to continue to have going forward. So we are coming up close to time. This is a quick session. We do want to turn it over to the audience to see if there are any questions related to Acuity Adaptability. It is a large topic. It has the operational impact, as Aaron mentioned. It has the design impact, and then it has the owner impact. But with that, we do want to turn it over to questions to the audience if they want to ask anything specific to the panel. Can you see questions, Corey? I cannot see them, but
no. Unfortunately, there's nothing yet. So okay. Either we hit all the messages and everybody completely understands the topic, and then gonna go on and implement these methodologies. So
well, we will wrap up then. So you've got people's email addresses here on the screen, so feel free to reach out to it. Again, a pretty diverse group. Luke from the owner standpoint. Aaron, a great background on the clinical side, and then Corey and Mark on the design side. So I don't think this is a topic that is going away. I think it is probably, as Luke and Aaron alluded to, there's probably an in-between here. But flexibility is going to be the key going forward, and there might be a place and a time to go down this road. But with that, we thank everyone for their time and appreciate the sitting in on this presentation.